All right, guys. So let's get rolling here today. So first and foremost, I want to welcome everyone to this evening's webinar on a very important topic, vertebral augmentation. This is a topic or a therapy that's very near and dear to my heart. So, well, again, welcome everybody. So tonight's goal today or goal tonight is to do basically a tour de force of all things vertebral augmentation. So just so you know who you're chatting with, I'm Dr. Williams. I'm a anesthesia trained interventional pain and spine specialist. And where I trained, there were two main facilities at the University of Utah. There was kind of the bread and butter chronic pain management center, but then there was also the Huntsman Cancer Institute where we did a lot of kyphoplasty, particularly for malignant fractures, not just osteoporotic fractures. And it was a stark contrast when you saw kind of the more challenging sort of regress more than progress kind of patients in a pain facility versus the more immediate, really true, groundbreaking, profound effect you have on people's life when you offer vertebral augmentation to patients. So that's something that stuck with me very, very early on in training, and something that I've taken forward with me in my practice and has really become a cornerstone of my practice, but also having a great opportunity here tonight, joined by some wonderful colleagues that will help me promote, educate, and really talk about this therapy because it certainly deserves more recognition. So one of the things that really attracted me to PSPS was the not just multidisciplinary approach to things, but a truly interdisciplinary approach to things, true collaboration between specialties. And in true PSPS fashion, that's exactly what we've assembled here tonight. So you have myself and Dr. Bandal, two anesthesia, pain and spine guys. You have two wonderful interventional radiologists and Dr. Dunleavy and Dr. Tony Brown. And it wouldn't be a good PSPS lecture without some surgical representation. So we have a wonderful orthopedic surgeon, Dr. Khalil, who'll be doing some of the heavy lifting on the back end here. So I don't think anyone here needs any introductions. I think the body of work from everyone here and the publications kind of speak for themselves. But yeah, looking forward to what they have to say. So what I want everyone to walk away with in broad strokes here, walk away from this talk just appreciating how powerful this procedure, this therapy is for patients and how much you can impact not just the patient, but their family. Knowing what patients to do this in, being more confident in patient selection, identifying these patients and making it part of your practice, but also understanding just the nuts and bolts about vertebral augmentation. And again, even talking about cases with a lot of the guys on the call here today, really picking up some of the nuances and some of the finer points of vertebral augmentation. So I don't have any disclosures relevant to today's talk. And rather than keep droning on why this is such a great procedure, I thought I'd sort of set the stage a little bit with two different quick case studies, and I'm going to call it a tale of two patients. So the first patient here is an 81-year-old female, 86-year-old female. She had a classic story for compression fracture, ground level fall, significant functional impairments, and was managed with conservative care. She had persistent pain despite months and months of conservative care. Nobody got any advanced imaging. They kind of just left her with bracing analgesics and bed rest. She finally got referred to me. Of course, I got an MRI as soon as I could, but when you compare that back with the previous X-ray, there's a couple important findings here that really explain why she was doing so poorly. She has a new fracture at T9 here. She has a worsening fracture near vertebra plana at T10. She has a worsening kyphotic deformity. And despite people telling her, oh, it'll get better, when you look at that stir sequence, you very clearly see that things were not getting better, right? These things are still lighting up. And so take a second here to pause and talk about the anatomy, talk about the anatomic issues with vertebral augmentation, throwing up some quick statistics here. So this is one of those situations with this cascade of fractures where past performance, I think, kind of does guarantee future performance, right? When you don't intervene and you don't offer this therapy to patients that are asking for it in terms of their presentation and history, this is unfortunately what you can get. And so just remember when we talk about cases, particularly when Dr. Khalil talks about mechanical augmentation, just remember that degree of kyphosis plays a big role in adjacent level fractures. To paraphrase one of my favorite rappers, like Notorious B.I.G. talked about, mo money, mo problems. I like to think the mo kyphosis, the mo fractures. So again, something to kind of think of. We're going to talk a lot about pain. We're going to talk a lot about functional things, but just think about the anatomy too when we're talking about these cases. So back to the case study real quick. This patient underwent a 4-level augmentation. I think Tony's going to talk a little bit about, how many levels should you do, can you do. She did have a nice reduction in pain, but I wonder if by the time she came to see me, she was just a little bit behind the 8 ball, right? She had gotten conservative care too long, I think. And so I really suspect that I really wonder if she could have had a better functional outcome. And I do personally think that her kind of personal morbidity and mortality curve was altered in a negative way by not having someone to see her, recognize her presentation, and offer her something more than just conservative care. Flipping gears a little bit here, a different patient. This is the other patient we want to talk about, an 83-year-old male, just a single level fracture. If you're quickly looking at this, you might almost miss the fracture, but his presentation was quite severe, even though the fracture was not. And again, we'll talk about patient presentation, patient selection, things like that. This poor guy went from basically opiate naive to a cancer level of opiates basically overnight just to get out of bed. Fortunately for him, he was referred to me for a timely vertebral augmentation, and that's exactly what we did. Simple, straightforward T11 spine jack, mechanical augmentation. Again, it was a fresh fracture, had some nice height restoration. Again, things that Dr. Khalil will probably touch on. But again, back to the living life. He has off opiates, no more bracing, within like a day or two. And he came to see me in follow up, and he told me, he's like, I'm the poster child for this procedure. And I said, absolutely. No arguments here, my friend. And this is not some exceptional case. Again, we're going to talk about techniques and ways to really do this procedure and do this procedure well. But this is the kind of outcome that I expect, and I know, guys like Tony Brown expect every time they do this procedure. So when we're talking about vertebral augmentation, we're really kind of talking also about conservative care or comparing it to that. I don't want to steal anyone's thunder, but just to quickly highlight that patients who tend to get this procedure tend to do a lot better. And I'm just going to tease that number needed to treat of 15. I think it's a very important number, but Dr. Dunleavy is going to put some context to that. So with that being said, hopefully we've kind of set the stage, got some neurons firing, and I'm going to let Dr. Dunleavy run with it from here and kind of talk about some data, osteoporosis, and the like.
Thanks, JD. And I got the driest section, so I will probably glide through and just let everyone really kind of enjoy the slides and then move on to the other parts and kind of use this as a basis for discussion if people have interest. So for me, disclosures, everything is related to spine, vertebral augmentation, spinal cord stimulation. Predominantly for me, it's on the diabetic neuropathy and cancer pain aspect, and then also on sacroiliac joint fusion. With osteoporosis, I think that even if we don't get too stuck on the actual numbers, the sad part, and that JD alluded to here, is that it's getting worse, right? Where it's not like we're getting better in terms of the medical management and the multidisciplinary collaborative approach. We're predominantly getting worse in terms of this. And so the big part of this is just realize that it's a massive number, right? 1 in 2 women over the age of 50 will sustain an osteoporotic fracture. And with that, it's something that we say when we see patients with a fracture is, what is the number one most important aspect that we have, a controllable factor to make people better? And we usually talk about cement deposition and cement volume. And the reason, many people ask us why that is because we don't have complete control of when they get to our clinic, just as that last case, right? It would have been better if we saw them earlier and if we could intervene earlier. But the next aspect that I always address is after we treat the fracture, we really need to treat the underlying problem and make sure that you're not coming back with an adjacent level fracture or a recurrent fracture. It's the number one aspect there. Just looking at the risk factors. And, number one, we talk about age and sex and predominantly elderly women. But as we go down these categories, I think it helps to identify the people that, for instance, have the alcohol, tobacco, or even the last category here. I think it's much more common than we think that medications are inducing some of these fractures. And it's something for us to consider is what can we withdraw or remove so that we can prevent further fractures. Even though it's not really part of this slide deck, I think we always go back to the aspect of, are we dependent solely on a DEXA scan? We're really not, right? And we can use the Endocrinology Society guidelines to say that a a fall from a standing height is a diagnosis of osteoporosis. And so, the obvious here is normal bone, abundant trabecula, osteoporosis, loss of trabecular bone, and then also disorganization, and then the end plate compression fracture. And, today was a classic example for me, actually, was a 94-year-old retired physician. And you just don't have the same, tactile feedback because he had such extensive osteoporosis, that the cannula just kind of floats through the pedicle into the vertebral body, and that can be even more challenging. And so as we look at, trials like Evolve, I think that it's really helpful for us to focus not just on back pain, but on function. And so Beal and some of his colleagues looked at that here with pain, function, quality of life, general health status. And, as Dr. Williams was mentioning at the beginning, I think that from the IR perspective, we generally don't do as great of a job as documenting function. And so it's been a big aspect for us to learn from the pain colleagues and say, really, don't just demonstrate you saw the patient back and their pain was better. What is their improvement in function and quality of life? Probably that's the biggest thing, in terms of the community, is having them understand that we can improve the risk for DVT, pneumonia, constipation, hospitalization, pulmonary embolism. With Evolve, we basically follow this out, right? 7 days, 30 days, 6 months, 12 months. And this is the part that I really like, is not just an improvement in back pain and disability for a short term, right? It's sustained. And as we look at this, we'll follow it out. Next slide. This is one of the concerns that some people have if they haven't read the literature, is that, oh, everybody ends up in the same place. And that's clearly not true, right? The people that have early intervention do better. They have better quality of life, better function, less morbidity, and also less opioid use. And if we look kind of globally at, multiple retrospective analyses. So, here in combination, 52 level 1 and level 2 articles. And that's where we start to get into the aspect, over 2 million patients reviewed, and really looking at a dramatic reduction in mortality. This is just to say, right, we all come at it from different perspectives. There's my brother-in-law, the veterinarian, my father-in-law, the orthopedic surgeon, and one of his close friends, general surgeon. And it's fun to approach it from different ways. And overall, I think there was a lot of concern, even in this group, just from the lay public review of vertebroplasty, until they understood the difference in outcomes and had tremendous support. I think that this may be another area that we can all improve upon. And Osteroff et al. Demonstrated 5% risk of malignancy determined when you actually take biopsies of what's considered an osteoporotic fracture based on imaging. And so, it's not as infrequent as we would hope, right? That you actually find that someone has an unknown metastatic disease that we didn't know about by just doing a simple biopsy at the time of vertebral augmentation. And this is just a mini, example of one type of bone tumor ablation. But again, to me, adding 6 minutes, 8 minutes to your case is really not much when you consider the incredible benefit that we can offer. I think for some people, this tends to be the area that Tony and I have the greatest interaction with in terms of functioning at tumor boards and working with the medical oncologist or radiation oncologist. But this also can be misunderstood, right? And that we're going for their business. And in no way is that the case, right? This is where we are actually helping them by allowing them to have better outcomes, and predominantly functional outcomes when they do radiation, because as we have all seen, right, it's sometimes hard to get a patient through an MRI when they're in tremendous pain. Imagine going through 8 weeks of radiation therapy to get any symptomatic improvement, when you can have symptomatic improvement in a day and then get through those treatments much easier. And so I didn't want to miss this. This will be predominantly Dr. Khalil's focus, but as we're talking about data, it's something that I oftentimes get on when people ask me, what would I do for my family? And so to me, my perspective is it's mechanical augmentation first, and then it's something else when that's not appropriate. But if we look, at DeLacy's study, you can see that, they had kyphotic angle reduction about half the time. And a third of those patients actually went to original vertebral body height. And I think that fits all with our experience as well. And as Dr. Williams noted, there's a tremendous long-term benefit, right, in improving that kyphotic angle in terms of the discogenic pain and the facet-related pain. And then as we look at some of these other studies, you look at adjacent level fracture rate of 2%. Now, if we look at Seiko's trial and think about 12%, and then we look at gold standard of bipedicular balloon kyphoplasty of somewhere between 20 and 40%, it's pretty incredible. If we can even believe that number is 2%, either way, it's very good. Then we get into the next studies of things that we've all been doing, but now are supported, right, in terms of treating traumatic fractures with or without retropulsion, with mechanical augmentation, and treating bone tumor ablation with mechanical augmentation as well. This is a kind of just a color code to just say, again, 52 level 1 and 2 studies. Basically, if we push this out even further, you'd see it's dramatically that vertebral augmentation is a superior outcomes. And we have to really push to find anything that even comes into question. And in those studies right there, you can find flaws in how they even came up with questions. And so this was what was alluded to before, right? If we look at over 2 million patients retrovective review, it's hard to find anything that has such a mortality reduction as vertebral augmentation. Number needed to treat to save a life is 15. If you compare that to something like number needed to treat with aspirin to ameliorate symptoms of a stroke, 3,000, or heart attack, over 1,500, or thrombolytics to save a life, similar data. But you would never think about having someone come in with a stroke and being like, maybe I won't offer them therapy unless you thought it wouldn't help. So, looking at this, it's very hard for me to see a patient like this and say, yeah, let's see how they do and see them back, especially when we know all of those cases like Dr. Williams saw of, progressive collapse, progressive kyphotic deformity, and less benefit as we get further out. All right, Dr. Brown.
Dr. Dunleavy, it is always the greatest of pleasures to hear you speak on data and your practice. Nice, always fun. Doing these things with you and John is like my favorite. So I'm a consultant for Stryker in Boston. So what I'm going to be talking about here is a little bit of the ins and outs of what is the reimbursement process for kyphoplasty, and that's kind of, so indications and complications are pretty boring when it comes to vertebral augmentation until you get into the idea of am I going to get paid for this procedure, and is what I'm doing actually supported by evidence, and so on and so forth. So we'll go through that. It's I find this fascinating, and hopefully you do too. So in general, our patient selection for this procedure is pretty obvious. These people have typically an onset of back pain that occurs with or without an inciting event. It's very interesting that, and one thing I'll never understand about vertebral compression fractures is simply the fact that sometimes they don't hurt at all. It's really hard to believe that somebody could have essentially a clinically asymptomatic spine fracture. I'm not sure I'll ever understand why that is, but it does happen. And then additionally, with osteoporotic patients, these people sometimes cough, they twist, they are laying doing nothing. I actually saw a guy in clinic yesterday who was watching TV and suddenly his back started hurting. Boom, T7 compression fracture, bizarre. But these patients have osteoporosis, and like Dr. Dunleavy suggested, it is really important that we treat the underlying medical disease in addition to treating the surgical problem, which is getting these patients back moving and functional. Because if we don't, we'll see them over and over and over again. And that's not a win for us because we get to do more procedures. That's a loss for the patient. So these patients have, when I see these patients in clinic, most of the time, at least in my clinic, when I see these patients as an interventional radiologist, they've been worked up to the degree that they've already got an MRI, I've already got imaging. Essentially, it's, they're being either referred from an orthopedic or a neurosurgeon's office or a family practice doctor, but they have imaging and I know they already have a fracture. And so what I'm doing is corroborating the imaging to their current pain situation. fracture pain is movement associated pain. So if they're laying in bed, they generally feel their best when they're laying in bed. Then they go to move, initiate movement, stand for a period of time. That's where their pain occurs. If it's in the thoracic spine, they may have a radicular pain that wraps around their chest. They may have a focal tenderness to palpation, or they may not. One of the biggest things that I run into with my nurse practitioners is they said, "Oh, I pushed on the guy's back and he said it didn't hurt." So I don't think that the visibly present fracture on MRI is the problem in this patient, and then that requires education. So in general, these patients can be sometimes a little bit confusing regarding their presentation, but we can nail down their pain pretty easily as far as patient selection goes. Now, why is it important to treat these? So Dr. Dunleavy already alluded to this. I refer to this slide as the wheel of death, where when you have patients who have a disabling compression fracture, those are the patients that need treatment because they stop moving. And if you stop moving, in general, I consider movement and longevity to be a one-to-one correlate. If you stop moving, you get old and frail and sick and dead fast, which is why that number needed to treat is so low at 1 in 15 or at 15 patients, because nothing kills you faster than stopping moving. Then they end up getting blood clots, they end up getting pneumonia, et cetera, et cetera. One of the other things that happens here, this is a kind of a generalized sagittal balance slide, where as you kyphose, overall your likelihood of having new fractures goes up because your center of gravity moves forward, and your likelihood of having a postural positional sort of pain goes up as well, because you have zygoapophyseal joint dysfunction and things like that. So you get all different types of pain, not to mention muscle spasm. So physical examination in these patients, like I said, it's movement associated pain. They change position, it hurts. Why? Because they're putting a weight on the spine. When they're laying in bed, there's no gravity and there's no body weight on the fracture. Given that it's given the fact that weight is translated in an axial direction through the spine, it is that axial loading that causes pain. Now, they typically have midline back pain, and the so-called chandelier sign, or a closed fist percussion on the spine, can be a both sensitive and specific method for identifying a painful fracture at the site. I tend to use it fairly regularly and document it when it's present. And occasionally, as Dr. Dunleavy mentioned, in patients who have cancer-associated fractures, lying flat is a big problem, so they can't lie on a radiation tube. Now, getting into what I think is interesting about this is the documentation of indications for the procedure here. And so what I will tell you is that documenting this procedure is one of the most finicky. It is so highly necessary to document this appropriately. And the reason for that is most of these patients are Medicare patients. Now, what I would guess is that most people who are listening to this presentation probably have never had a proactive denial from Medicare for one of their patients. In general, you say, "Oh, I want to do X, Y, or Z on a Medicare patient," and Medicare says, "Neat, go nuts," or if they respond at all, right? It's typically the private companies that will do an authorization denial. You'll have to do a peer-to-peer. You don't do that with Medicare because Medicare authorizes everything on the front end. But what is the devil in the details there is that Medicare is the government, and the government gets their money. So if you have inappropriate documentation, the way Medicare gets their money is they hire third-party companies to come audit you. And if you have inappropriate documentation, you'll have to pay them back. So if you get a Medicare audit and you have a busy kyphoplasty practice and you haven't good documentation, you may owe them money for years of kyphoplasties, as they are allowed to go, just like the IRS can go back and get your money from 5 years ago. Medicare can go back and get their money from 5 years ago on your inappropriately documented kyphoplasties. So it is critical that you document appropriately for these procedures, particularly in the outpatient world, such as is the case in my clinic. So the important thing to know is that their guidelines are based on our guidelines. So if you're following our own data, you should be fine as long as you document it. I'll give you an example. Yeah, how to get reimbursed and keep it. So here's an example for you. I've got an OBL clinic. This is a patient that I might see in the OBL clinic. So they come in, and here's their MRI. They clearly have edematous fracture at T8. Their onset of symptoms was 6 weeks ago. Their pain is 6 out of 10 with movement, but it's a little bit better. When they had the actual onset of fracture 6 weeks ago, their pain was 10 out of 10. So we'll say their pain is, getting a little bit better. Symptoms that obviously correspond to imaging. Let's say they have a chandelier sign. And would you, based on this documentation, would you treat this patient and expect that you would be, number one, reimbursed, and that you would ultimately keep that money if this is a Medicare patient? So we'll go into it. If you don't recognize this this text, this is the Medicare LCD for kyphoplasty. I could recite this to you from rote memory because I have to, because I built our dictation templates based on this information. So I won't read it to you. Rather, what I will do is I'll give you a couple of scenarios. And notice at the bottom that there's a question of continuum of care. All patients presented with VCS should be referred for evaluation of bone mineral density and osteoporosis indication. So that means that if you don't refer or treat these patients for their osteoporosis, Medicare may come back and take the money from your kyphoplasty away because you didn't appropriately manage continuity of care on these patients. So make sure that you have a method of treating these patients. So moving into, here's vignette number 1. So this is an in-hospital consult. So if you're a hospital interventionalist and you get a consult from the ER for a kyphoplasty, these are the criteria you have to meet to be able to treat this patient and be reimbursed for it. So it has to be a painful fracture that has not responded to some sort of conservative measure, narcotic, non-narcotic medications, PT, or bracing. You have to document that. It has to be less than 12 weeks old, and advanced imaging has to be positive on it. You have to have an MRI or a bone scan. And they have to be hospitalized with a VAS greater than 7. So if you meet those criteria, you can do a kyphoplasty on an in-hospital and on a hospital inpatient, and you will be reimbursed for that procedure, and you will not have to pay them back for it. If you do not document this, there's a chance that you will be denied and ultimately will not be reimbursed. Here's an outpatient. For an outpatient, they have a painful fracture. It has to be painful. It can't be an asymptomatic fracture on imaging. It has to have not responded to conservative therapies, narcotic and non-narcotic medications, PT, or bracing. It has to be less than 12 weeks old from symptom onset with positive advanced imaging. And it has to be, they're non-hospitalized with a VAS greater than 4, and their pain is worsening. There's the critical thing right there. In this vignette, a patient with worsening pain associated with their fracture is essentially a trump card to treat them and be reimbursed. Final one is an outpatient with a painful fracture with stable or improving pain. So a patient with stable or improving pain, they have to have 2 of the below, which is they have to have greater than 25% height loss. They have to have progression from original imaging. So you have to have interval imaging showing progressive height loss, like the one that Dr. Williams showed us on the first case. He would be reimbursed for that procedure because there was progressive height loss. They have to have a significant kyphotic deformity at the incident levels. Or they have to have a Roland-Morris disability questionnaire with a greater than 17 response on it. So you have to meet this criteria to be reimbursed for the procedure. So let's go back. Here's the Roland-Morris disability questionnaire. So anytime a patient comes in for a kypho consult in my clinic, they fill this sheet out. And then when they come back after their kyphoplasty for their follow-up and their osteoporosis treatment, they fill it out again. And that's our way of objectively measuring their subjective pain relief, right? And so we can document that and show that our procedures are working. But if you don't have them fill this out, you've already eliminated one of the criteria that are going to get you reimbursed for this procedure. So I would recommend that you do that on all your patients. So if we go back and we look at our clinic presentation, we have an onset of symptoms 6 weeks ago, so that's within criteria. The pain is 6 out of 10, that's within criteria. It's slightly better, so they fall into the category of stable or improving pain. What that means is that they have to meet one of these, 2 of these 4 criteria, right? So I'm sure I could put a caliper on T8 there versus T7 or T9, and I could make 25% out of that. I'm a radiologist, and I have that sort of gift. So we'll give him 25% height loss. Well, I don't have a progressive height loss because this is the only imaging I have. He's not significantly kyphotic. So what I'm doing is I'm hoping that he fills out that Roland-Morris and it comes in at greater than 17, or else we're going to have to figure out some other criteria in order to treat them, or we're going to treat them conservatively, right? That is a decision that you'll have to make. So you can't necessarily treat these patients if they don't meet the criteria and expect to get reimbursed. And is that appropriate? Well, here's your answer. So this is from Drs. Hirsch and Beal. This is the this is the Spine Journal 2018 RAND UCLA appropriateness criteria for kyphoplasty. I use this thing like crazy. There's a web app for this that you can go through and understand who should be treated for their fractures. So let's go through it. Patient has back pain. You examine them with history, risk factors. If they have an intermediate or high probability of vertebral compression fracture, you get advanced imaging. Then we run over to this chart here. Okay, so now let's look at, and they say, okay, well, the advanced imaging is negative, but they have worsening symptoms. So there's that key word, right? Their symptoms are worsening associated with their fracture. And now you have an effective green light. Positive imaging with stable or improved symptoms. What does it tell you to do? It says, well, look and see if there's two unfavorable factors. Well, we recognize these, right? These are the exact same ones from the Medicare LCD. So what this shows us is that Medicare essentially cut and pasted this study into their LCD. So if you want to blame somebody for not doing a vertebral compression fracture and not getting reimbursed for it because you don't meet criteria, blame Dr. Beal. Or rather, what you should do is you should treat the patient appropriately, get interval imaging, treat them for their osteoporosis, and if on subsequent imaging they lose subsequent height and their pain then worsens or stays stable, plateaus, then you can treat them, but you may not be able to treat them today because of that criteria. Or you could treat them and just expect that you will not be reimbursed for that case. I hope all that makes sense to you. This is like an hour-long discussion that I'm trying to pack into 10 minutes. But I think this stuff is really interesting, and it really makes a difference in your clinic if you're a high-volume center for kyphoplasty, such as mine, that we want to make sure that we're able to keep the lights on and treat patients appropriately. So if you don't know the Spine Journal 2018 RAND UCLA study, print it out, read it, commit it to memory, and then compare it to the Medicare LCD, and you will find that they are identical, and then treat your patients in that manner. So this is just another graphical representation. If your patients are feeling better, they're probably not good candidates for augmentation unless they meet those criteria of a severe kyphosis or a progression of vertebral height loss, as the criteria suggests. If they're plateauing or getting worse, they become candidates for treatment. So getting into contraindications, and I know I'm probably running over because I always talk too much, but what I'd like to get to is what Dr. Williams suggested, which is there are relative contraindications to vertebral augmentation. And they're kind of the ones you think of, but in the LCD criteria, so in the Medicare reimbursement criteria, they will not reimburse you for more than 3 levels in one incidence. So if you bring a patient to clinic and they've got 4 fractures, you will only get paid for 3 of them. And that is based on a paper from Dr. Anselmetti from like the year 2003 or something like that. What's important to know about that is there are numerous studies, such as the ones that I have cited below on the bottom of the screen here, that have suggested that there is no increased risk with treating more than 3 levels. Like the one by Dr. Zidane, they treated up to 7 levels at a time and found no significant increase in risk to the patient based on those treatments. Now that said, there is a anecdotal suggestion that marrow displacement into the vascular could set patients up for what essentially amounts to like a fat embolus type of scenario. I can't necessarily refute that argument, but again, there are studies that say that that have suggested that treating more levels than 3 in one setting is feasible and could be appropriate depending upon the patient's particular scenario. I just kind of initiated treatment. I have this very, very unfortunate gentleman who had ulcerative colitis. He's only 62 years old. Went on prednisone and now has 10 consecutive fractures in his spine. And I'm trying to do more of a reconstructive augmentation on him. So I'm using multiple spine jacks, and I'm doing this in my OBL. And so I saw him on Monday. I did a 4-level kypho with 2 separate spine jack placements, and I'm bringing him back on this coming Monday, and I'm going to do the remaining 6 levels on him, knowing that I'm going to be reimbursed for 3 levels for the first time and 3 levels for the second time. And I'm just going to try to do the right thing for the patient, because I believe that 3 incidences in order is too much in his scenario. I'd like to get it done in 2. Those are the type of I suppose concessions we make with sometimes with these patients, where the right thing to do is maybe to treat extra levels and just know that your reimbursement is not going to be on a per level basis. That's okay. The data supports us treating more than 3 levels. Just know that there is no support from the insurance companies on doing that right thing for the patient, if that is the right thing for the patient. So 3 levels is all you'll get paid for, though there is data to do more than that if necessary. Any of the strong contraindications, please respect those. And then there's absolute ones which include not an asymptomatic fracture. So your complications associated with kyphoplasty are incredible, like infection, because we live in a dirty world. There's simply nothing scary that we put our needles through to cause major bleeding at a kyphoplasty, unless you go out the front of the bone and hit the aorta, right? Which please don't do that. And then some sort of cement extravasation, either forward or backward, would be an injury to some adjacent structure that could cause neurological damage or whatever. So in my own practice and the way that I do kyphoplasty, my approach is to do what I call Tony's 3 rules to avoid to never screw up a kyphoplasty. And rule number 1 is set up a perfect AP and lateral before starting, because you think that everything looks like a sawbone model until you see a patient like this and you're trying to do an augmentation on a severely scoliotic patient with a vertebral compression fracture. Then that lateral becomes quite difficult to make. So take the time to make sure you get a good one and you know where you are, so those needles don't go in a weird place. Don't allow the needle to transgress the medial wall of the pedicle before it's in the back of the vertebral body on a true lateral, right? Because then if you don't, you get this, right? You get a needle right through the fecal sac, which I think Dr. Khalil would agree is something that he would then have to deal with, and that's not going to end well. And then all movements of consequence occur in the lateral projection. That is so that you don't miss is ending up in the epidural space, whereas on the AP it looks like it's in the vertebrae. So if you follow these 3 rules to never screw up a kyphoplasty, you will avoid essentially every complication that I can think of for kypho. That was a lot, and I now turn it over to my colleagues.
Thank you, Dr. Brown, for that really nice overview of patient selection. And then, of course, we had a really nice overview of vertebral augmentation. Now, I'm just going to quickly talk about the actual procedure of balloon kyphoplasty. Here are my disclosures, nothing relevant. So we're going to start off with kind of the overview here of the balloon kyphoplasty. So you guys have probably seen this image very frequently. Essentially, the procedure is done using both AP and lateral views. A lot of times you'll see this kind of 5 projections that are marked on here that are used to kind of follow the procedure as we walk in from the AP to the lateral views. So basically these little dots here labeled from 1 through 5 is how you move forward with the procedure. So it kind of tells you where you are based on the AP and the lateral views. So as you can see here on this picture on the left, when you're at that first mark here, kind of right on the lateral wall of that pedicle, you're basically docked in on the pedicle on your lateral view. And as you kind of move your needle more medially, you kind of progress in the lateral view as well. And then the most important kind of landmark here is that 3rd mark here. As Dr. Brown was mentioning, this is the medial wall of that pedicle. And you want to make sure that you don't go past the medial wall of the pedicle in this view, in the AP view, before you are kind of past the posterior wall of the vertebral body here. That's kind of the biggest safety view, and we'll kind of walk through this a little bit more. So here's kind of a general overview of the procedure. We'll walk through these steps a little bit more in a little bit of detail, but essentially you first take your needle, put it into the posterior 3rd of the vertebral body. You use a drill to kind of drill through that trabecular bone to kind of soften it up a little bit more. And you kind of drill into the anterior 1/3. You then insert your balloon, make sure the balloon is all the way inserted inside the vertebral body. You inflate the balloon, you inject the cement, and then after that, you withdraw the balloon. So as Dr. Brown was mentioning, really important to get a really good image here when you do the procedure. Just like most procedures, the image, the AP and the lateral will kind of make and break the procedure. And this way you want to make sure you set yourself up for really good success. So you want to start off in the AP view. Make sure that the end plates are parallel to each other. So you kind of do a little, movement of the CR machine if you need to. And then you want to make sure that the upper border of the pedicles is kind of right next to that superior end plate, almost touching it. And then you also want to make sure that you can kind of have your spinous process symmetrically right in the middle of the vertebral body and get this really nice image. And then you also want to kind of just make sure with those end plates, again, another good trick is to make sure you don't have any of that halo effect going on. So that way you know that those end plates are kind of lined up perfectly. And then again, you kind of have your vertebral body lined up so that the spinous process is right in the middle. Same thing with the lateral view. Again, you want to have the end plates lined up, make sure that they're parallel. Sometimes this can be a little bit more difficult, especially if you have a little bit of depression of that superior or the inferior end plate due to the compression fracture. So that can become a little tricky sometimes. And again, just make sure that the pedicles are superimposed. As Dr. Brown was also mentioning, depending on the size of the fracture, if it's kind of only a 25 or 35% compression fracture, sometimes it can be a little difficult to tell exactly which vertebral body is fractured, especially when you're working more up in the thoracic spine area. So a lot of times if you can't tell on the AP view, and sometimes if the spine is really, has a big curvature to it, I always check the AP and the lateral views, and you can put a little pointer on there to make sure you're treating the right vertebral body. Don't get kind of thrown off by some of the tougher x-rays that may be out there. So step 2, you want to make sure that you can really see that midline pedicular wall whenever you're about to start the procedure. So you want to make sure those medial borders are nice and clear and you can see them. If you're doing bipedicular kyphoplasty, you want to make sure both of those pedicles are nicely and clearly visible before you move forward. Usually to start off with, you'll make a small little incision, 2 to 3 millimeters, a little bit kind of superior and lateral to your docking point. And if you're working on the left pedicle here, your docking point will be the 10 o'clock position. If you're working on the right pedicle, it'll be right at the 2 o'clock position. So usually I'll make my incision about 1 to 2 centimeters superior and lateral to the entry point. And this just depends on the body habitus of the patient. If you have a skinnier patient, sometimes you can start really kind of close to it. If it's a larger patient, more obese patient, you may have to even go really further out here. Once I've made that little nick, just a little stab wound, I'll take a spinal needle, like a 22 gauge needle, and basically dock onto this pedicle and really anesthetize that area. A lot of times that's all it takes for the patient to tolerate the procedure. I'm in private practice, so most of my kyphoplasties that I do are just in the clinic. So that's why in the office suite. So that's why it's really important that I really anesthetize it. Usually I'll give people just a little bit of PO Versed, and that kind of gets them through the procedure. But of course, if you're doing this in the ASC or in the hospital, then you have more of the anesthesia services available there. Perfect. And then same thing as we kind of talked about, we're kind of work through that 1 to 5 trajectory in the lateral and the AP view. So a lot of times you're going back and forth between the two views. Sometimes when we do these in fellowships, we had access to 2 CR machines, which would make this much, much easier. But most of us out in private practice, we just have the 1 CR. So a lot of times you'll go kind of back and forth. So again, you really want to make sure that you don't go past this medial border of the pedicle that you're working on before your needle passes that kind of posterior line of the vertebral body. Now, a lot of times to kind of help with this, I'll also use a beveled trocar, so that way even if you're kind of getting close to that medial border of the pedicle, but you're not quite where you should be in your lateral view, you can always turn the beveled trocar, which gives you a little bit more breathing room to kind of advance it a little bit more, so that you're kind of past that wall and into the vertebral body, that we can kind of continue pretty easily and move forward with the procedure. So here, we've inserted our needle. We're in that kind of nice area, that posterior 1/3 part of the vertebral body. So at this point, you can remove the stylet. And then here you have that optional part that Dr. Delaney kind of mentioned in his part of the talk, where you can do that biopsy for the bone to check and see if this fracture was pathological or not. I didn't realize that the incidence was as high as 5%, so that's pretty high. A lot of times I won't do this part if I'm just in my office suite, but I have done the bone biopsy, but maybe I should start doing a little bit more given the high incidence that these fractures can be malignant. Next step, you insert your drill through that same trocar, and the drill is going to go into that anterior 1/3 of the vertebral body. And you have to sometimes be a little bit careful when you insert this drill. A lot of times that bone is really soft, so it doesn't take very much for that drill to kind of go through the bone. And you have to be, of course, really careful that you don't go through the anterior wall of the vertebral body. As you know, there's a lot of important structures out there, so just be really careful when you do this. And as Dr. Brown was mentioning, all these kind of movements that you're doing of consequence, make sure you're in the lateral view. And the purpose of the drill is to basically create a channel for your balloon. That way the balloon can go in, and then the balloon will be able to expand. So it just kind of softens up that bone for you. So then you take the drill out, and then here you have the balloon insertion. The balloon should be all the way in, kind of resting either kind of in the anterior third, the more proximal end, and then kind of going across the middle part of the vertebral body. And then, of course, you want to make sure that both of the these little markings of the balloon are through the cannula and into the vertebral body as much as you can have it. Sometimes you'll see one of these dots kind of get stuck in the cannula. If the bone is really hard, you may have to take the balloon out, reinsert the drill, and do a little bit more of the cleaning out in that area to make that bone a little bit softer so that the balloon is fully in. Of course, if that distal part of the balloon is stuck into that cannula, you won't be able to inflate it. You won't get as much lift and height restoration, and your pressures will be really high. So you really won't get a very good procedure. So make sure that drilling part is really important. Make sure you do that well so that your balloon will just kind of go in very easily without any type of problem. And don't try and force the balloon as well. A lot of times you think it'll, if you kind of keep pushing it harder, it'll give. You don't want to, damage the balloon or rupture the balloon. Then you'll have kind of contrast going all over. And a lot of times if it kind of bends or kinks, it just doesn't inflate as well. So really make sure you have that good channel before you put the balloon in. Next step essentially is to put some contrast into the balloon and inflate the balloon. And again, you're doing this in the lateral view. And then you just want to go up on it slowly, inserting as much volume as you can. You want to make sure that the balloon does not touch the cortical bone. Stay away from the superior and the inferior end plate, but try and put as much volume as you can. Make sure you keep an eye on your pressures in the balloon, depending on if it's a 400 or 600 psi balloon. Of course, you don't want to go beyond that because it could rupture, and then you just have that spillage of that contrast everywhere. And then next part, so you stop the balloon inflation essentially when you've kind of inserted as much volume that the balloon will take. You can also stop the insertion or the inflation of the balloon when you feel like you have pretty good coverage, like in this second image here. Here you don't really have to put any more volume in there because you'll have a really good coverage when you put the contrast into that vertebral body. So next step is to deflate the balloon. So you just pull back on it. You withdraw the balloon. At this point, you can start to insert cement into the vertebral body. And usually when I'm doing this, I'll kind of push my little trocar a little bit into the anterior 1/3. I'll start to fill the cement there and then slowly withdraw that channel back as that part of the vertebral body gets filled with cement. So I'll start off in that anterior 1/3, pull it back a little bit, do a little bit in the middle third, and then do a little bit in the posterior 1/3. And then, of course, if you start to notice any type of leakage of that contrast or any type of extravasation, you want to stop immediately because you don't want that to keep going. So usually I'll fill a little bit, a couple of cc's, take an x-ray image, make sure everything looks good before moving forward. And then here again, make sure you have a nice fill in the vertebral body of the cement. You want to try and put as much volume of cement as you can in there. Of course, don't overdo it. Make sure you don't have any sort of a leakage of the cement outside of the superior and inferior end plates. And then you basically are trying to get something like this where you have really good coverage of the cement, from top to bottom and side to side. That way you'll get really good clinical effect of the procedure. Moving forward, so of course there is, you can do the kind of traditional bilateral bipedicular balloon kyphoplasty, and a lot of people these days are also doing the unipedicular approach. So essentially it's the same type of a procedure, a little bit different. So with the bipedicular approach, you're coming in a little bit more medially, and you have a little bit better coverage of the posterior part of the vertebral body. But whereas if you're doing the unipedicular approach, you're going to come in a little bit more laterally as far as the entry point goes, and then you're more of your fill is going to be more anterior and a little bit more lateral. So you avoid a little bit of that posterior part of the vertebral body. So a lot of it also depends on your imaging, what type of a fracture you have. If the fracture is more in the posterior part of the vertebral body, maybe you want to use the bipedicular approach. But if you want to, if your fracture is more anterior, then maybe this unipedicular approach will work as well. Of course, there's a lot of advantages to the unipedicular approach. It's quicker, less anesthesia time, less invasive, more efficient as far as the procedure goes, especially if you're treating all those patients with a bunch of different fractures, the sick patients, it's elderly, you want to reduce the procedure time, this can be a good strategy. And just because you started with the unipedicular approach, if you're not getting that coverage of the contrast or the balloon to go all the way over across midline, you can always just come back in with the second side and do a bipedicular approach at any time as well if you're not getting very good coverage. As far as the data goes between the two approaches, there's RCT kind of labeled here that shows that the outcomes are pretty similar using the two approaches. So I know a lot of people these days are doing unipedicular approach because of the previous things that I mentioned. A lot of times I'll start off with that as well. And if I need to do the second side, or if the fracture is more posterior, then I'll just start with the bipedicular approach. The process of the unipedicular approach is basically the same thing. You're just accessing the pedicle on just one side, and then you essentially kind of insert the needle and then basically make sure you're across midline when you're placing that needle in. That way you'll get really good coverage of the balloon on both sides of the vertebral body. All right, I think that's my part. I'll put it off to Dr. Khalil.
Thank you. I'm just looking through. I just want to build on everything that was said before. Okay, so just to build on everything that's been said before, this is pretty important slide actually. When you look at it, the bipedicular balloon kyphoplasty is just a summary of the 3 ways to do it. You're going from lateral to medial. Balloons are what we call them kissing in the middle. Unipedicular, you start a little lateral and you just kind of curve it around the anterior vertebral body, and that's how we do unipedicular. And finally, to talking about the mechanical augmentation with the spine jack system, because it's the only device on the market that allows it currently. I like to stop at this slide and go over some really important concepts that pertain to spine jack application. So first of all, you'll see that it's a bipedicular, so always recommend doing this bipedicular. My personal recommendation is also going transpedicular. People always ask me, can you do it extrapedicular? You could. The preference is going bipedicular so that you can rely on the pedicle to act as a floor to be able to achieve that height restoration. And then finally, we don't want to put the spine jacks too convergent medially, because if they touch each other or if they get into each other, they can prevent the expansion. It's not the end of the world, but typically I like to end. If you can see here my pointer, I like to end if you look at an AP, the tip of the spine jack should be between the spinous process and the pedicle, ideally. So that's kind of my target on an AP. So the steps doing the spine jack procedure, I will contrast them to the balloon kyphoplasty in terms of procedural steps. So first of all, you're going to access, like I said, lateral to medial, but not as medial as a bipedicular balloon. But here, if you think about kyphoplasty, you're putting a hand drill through the cannula, whereas with spine jack, instead of putting a hand drill, you're putting a wire exchange, and then we're drilling over the wire. And that keep that in mind when then I may mention it later, or I'll mention it now. If you have a very, very skinny pedicle, don't use a larger spine jack, because the reamer is not protected by the cannula. Whereas it's in kyphoplasty, it's going inside the cannula. Spine jack is going over the wire, so you don't want to ream out the pedicle. After you've exchanged and placed the wire, you use a reamer, the hand reamer, that typically pretty much mimics the size of the spine jack, if you see it here. And the size of the reamer is the exact size of the spine jack, so that's how I know that my size is good and how far forward to go. I typically trying to go as forward as possible, typically to restore the anterior column. Then we go to the other side and do the same thing with the reamer, place the spine jacks and expand sequentially. I like to expand one side at a time. And typically I'm working with my resident or fellow, and we're each on one side. So we do couple turns on each side, take an X-ray, a couple turns, and take an X-ray. Then we don't remove the balloon, just like unlike a balloon kyphoplasty, we don't remove the device, we keep it in, and we fill with cement, of course, under multiple AP and lateral shots. So we'll go to, so that's the same steps illustrated by with X-rays, actually instead of the cartoon. So you're seeing the cannula in one, then followed by the guide wire, reamer of the wire. Template to me is honestly, I call it an optional step, because the template size is the size of the reamer, but sometimes if you use it, you can clean out the bony channel. So some people like to use this. Then you put a cannula, plastic cannula plug before going to the other side, close spine jack. Always, always, always. I like Tony's recommendations to stay out of trouble. I would add two things also that I probably add write a book on how to stay out of trouble, because we've seen, over thousands of cases, a lot of those things not to do, especially working in a big academic center. So I would add two things. Always inject cement on a lateral film, and always get an AP before you inject the cement, or in this case, before you expand the jack, because although your cannula may have been in the vertebral body on AP, by the time you reamed and put the spine jack in, you might have breached laterally. So I always get an AP and save that shot. And again, my other recommendation, always inject cement on a lateral X-ray. I've seen people inject on a AP and it's not recommended. Then again, this is more of the same. Like I said, bipedicular, lateral to medial, but not very medial. What are the features of spine jack? Why do I even use this device? Balloons are great and the data is good. I think the height restoration is improved with the spine jack, so you can get better radiographic height restoration, better kyphosis correction. And we know that kyphosis equates with further fractures because of the anterior moment. And so this leads to, in most of the studies that have been done on spine jack, even fewer adjacent fractures than a balloon kyphoplasty. And we know from the FREE study and multiple other studies in the literature that kyphoplasty leads to less adjacent fractures than non-surgical treatment. And so my favorite aspect about the spine jack is that it is a anatomical restoration, whereas balloon kyphoplasty is very good. However, the forces exerted when you inflate the balloon are centrifugal, so they're going away from midline, which most of the time will give you the desired effect, but sometimes you'll see the balloon will not reach that end plate and really pop it or reduce it. But with spine jack, you are in control, but basically, however you put the spine jack, the recommendation is put it under the end plate in the direction that you want to reverse that force that created the fracture. So it's a axial load fracture. We want to reverse it with an axial expansion. And every time, hopefully every time you do this, it never gets old when you look on the X-ray and see that end plate pop. I did a couple yesterday, and it just always amazes me how powerful that restoration of the anatomy is. Now, the indications, just to go over real quickly, is the initial indication for spine jack, which was a unique device of its kind, was for painful osteoporotic compression fractures. I stress the word painful because we don't treat painless fractures. If no symptoms, we don't treat them. I don't try to fix deformity by doing kyphoplasty, so they have to be painful. The second indication that was FDA cleared was the traumatic compression fracture. I'll show some case examples. And finally, as of maybe about a year and a half ago, it was approved for malignant lesions in conjunction with cement, of course. And frequently we do this in conjunction with other methods such as ablation as well. One important concept here, some people think that the kyphoplasty leads to more fractures. Quite the opposite, actually, because the theory and the science shows that whenever a fracture happens, the force transmitted through the end plate is much greater. And also those same biomechanical studies show that reducing the end plate fracture leads to diminished stress at the end plate, therefore leading to less fracture. Also, I talked about the concept of reducing kyphosis as an aid to reducing adjacent fractures as well. And sometimes this video works and shows gentle expansion. So I always say gentle bipedicular expansion. You'll see the end plate pop like so. And then you don't remove anything, you just keep everything in place and start injecting cement also slowly under multiple shots. This is not the time to save radiation. I typically tell my residents and fellows is every turn of the, so I use the cement injector personally, that's my preferred way to do it. Or you can, if you're using the plugs, you can say every 0.3 cc's or 0.4 cc's. For me, it's every, well, now with the new cement injector I use, every click is a 0.1 cc, which I really like. So every 3 clicks we take a shot. So this is where we take a lot of x-rays, especially at the thoracic level. If you forget to take an x-ray and do a couple turns and you end up in the canal, or you end up even worse, in my opinion, in a vessel, that could lead to problems. So multiple shots while injecting. We talked about the SECO study, and this is the reference. I'm not going to repeat the excellent presentation by my friend Dr. Dunleavy. And so this is the reference if somebody needs it. It's a European study that showed the superiority, clinical superiority of spine jack versus balloon kyphoplasty. And so just to get into a few examples, I mean, these are not, honestly, these are day-to-day cases that I do. They're not the kind of maybe the most dramatic, but they're I've chosen them for a reason. So the first case is almost a 90-year-old with severe kyphosis after multiple compression fractures over her lifetime probably, but one dominant compression fracture in that upper third of the thoracic spine that you'll see here lighting up on STIR. And why the reason I chose these fractures is that in my hands, or in my opinion, this is not amenable to a balloon. Whenever you see that pancake vertebrae, typically the balloon will squirt either anterior on the disc space or not exactly where you want it. This is where you need that. And I still, my disclaimer here is that I still do tons of balloons whenever the situation does not need a spine jack. The 3 months prior, so she had those little fractures, but she did not have that significant kyphosis. So this is somebody who is significantly debilitated by this new onset kyphosis. The way I do this is always I go again transpedicular. I try as much as possible to be in line with the vertebral end plate. And in this case, we did get a dramatic expansion. It's always better. You always get a better expansion that you think you're gonna get, especially on I'll say a freshly acute fracture within the first few weeks. When you're going into the 2-3 months after, typically I would not see such a great expansion. And we can talk all day long whether we should do those fractures at all or not. But I would say with spine jack, earlier is better. Even with balloon, earlier is better if you commit to treating those patients. Of course, granted the indication for treatment are there. And so so this is one that we were able to restore kyphosis. I would never think about, I say never, but I would really not want to instrument the patient with ghost bone at 88. This patient did very well. She had actually a VS of 0 and was able to go back and take care of herself. She still lives alone. She still independently alone takes care of herself. Similar fracture with a little higher energy. So this kind of going into almost the traumatic, fell down a full set of stairs going into the basement with also this significant compression in, I think it was T6 or T7, also showing same thing. So you put them on the table, and I use a Jackson frame. So it kind of opens up. And when I have those fractures, I try to put the chest pad a little high just so gravity opens it up. And typically it always opens better than you think. Then you go spine jack, fill with cement. Patient did very well. The other thing I would point out is with spine jack, typically you end up using less cement than with balloons because first of all, you have the jack there that's stained, so you don't have to fill the entire cavity like you fill a balloon cavity. Going into real trauma cases, 35-year-old, high speed MVA with, and I put this fracture for the dramatic effect, but also to show that manubrium fracture. So this turns it into from a 3-column injury to, if you will, a 4-column injury because you have the fracture here, but it is a 3-column injury going all the way into the spinous process and this anterior middle column and manubrial fracture. And so the patient has also 2 fractures that are a little more benign here. We decided to fix this fracture with spine jack and fixation, just because of the 3 colon or the 4 colon, if you will, and the bottom ones with with a simple spine jack without fixation. And so that's I always do the spine jack first, typically, just to see how much kyphosis correction I'm going to get with the spine jack, then put my screws, and then I treated the bottom fractures with spine jack alone. Also, just note here that if you, I know we do a lot of things that are off-label and talk to patients about it, but the on-label indication for treatment of traumatic fractures, what's the traumatic fracture is one that does not happen under physiologic loads. So it's not the pathological osteoporotic fracture. It's one that happens under supraphysiologic load, like MVAs, fall from ladder, etc. Only spine jack is approved, is FDA has on-label clearance for the treatment of those fractures. Balloon kyphoplasty is not on label. Whether that matters a lot or not, and I'll leave it up to you. So that's the post-op X-rays. And then finally, I'll show this this fracture with a little more, type A plus fracture, I would say, at L1, because you get a little spinous process splaying. This was a very unreliable person that I knew that probably was not going to follow up in my office for I would say for legal reasons. He was I think he was going to jail after the fall. So we wanted to be a little more aggressive, just give him a fixation that is not going to fall apart. So in addition to the spine jack at L1, we also offered fixation. He had a little superior end plate at L2, so I kind of bypassed with screws, went down to L3. And again, I always do the spine jack first. Anti-kyphotic maneuvers are done first. We have, I think, multiple shots here just showing that expansion of the superior end plate. Then we put the cement, take an AP, and then I go ahead and put my percutaneous screw fixation. These are not open fusions. These are perc screws. They go pretty quickly. Somebody asked me one time why I didn't put any cement in that L2, and I honestly don't recall, but I didn't feel like I had to. And what's dramatic to notice is the improvement of kyphosis from the preoperative situation to post-op, and that's the pre-op. He did come back for follow-up to the ER, of course, and to get his staples out. And a lot of times we put staples to make those people come back for follow-up, at least to see so we can see how they're doing. And you can, whenever somebody comes to the ER, they always get a CT scan for some reason. And so, but it was nice because you can see the improvement in kyphosis and the restoration of that vertebral body anatomy at L1. Cement is well contained, and again, kyphosis correction is most important to me. And so I think that's all I had. And thank you again, Dr. Williams, and great co-faculty as usual. Dana, Tony, it's always good to get the gang together. And Dr. Vandal, nice to meet you.
Fantastic. Well, again, I think for the sake of time, we're probably just kind of skipped a lot of the panel discussion here. But I think honestly, we covered a lot of the high points I was hoping to cover. I think you always want to leave the people wanting more kind of thing, but I think we'll just kind of leave it here for that. But again, I want to thank everyone here on the panel for their time, their expertise. Again, we covered a lot of ground. For sure. So again, thank you to our sponsors, both Stryker and Medtronic. They make some really good tools, again, that you've seen firsthand in our presentation here today, and allows you to really take care of your patients. Quick plug here for a couple things. There's a call for abstracts, $500 stipend if you are lucky enough to receive that. So if you're doing any novel research, feel free to consider submitting that for the upcoming conference. We got some research grant proposals going on as well. So again, if you have some novel research going on, I'm not sure if this is part of the lit track, but yeah, some funding to be had there if you guys have any projects going on as well. And then finally, of course, all these things kind of building up to the annual conference. We'll be here before you know it, October 3rd through 5th, Newport Beach. So pretty great location, pretty awesome place to consider going. But yeah, just in some concluding thoughts, I think, really, no matter who you are watching this webinar, again, get involved with PSPS first and foremost. It's a great, truly interdisciplinary organization like I mentioned, like you've seen here tonight, right, and demonstrated live and before you. But whether you're a medical student just learning about this for the first time, whether you're an established practitioner doing a lot of this, I think anyone watching this talk, if again, to take nothing away from it, get involved, advocate for your patients, advocate for this therapy, and I think you'll really see some positive benefits for when you do that, no matter what level you are kind of watching this kind of presentation. So with that being said, again, I want to give a big thanks to all the faculty here. Virtual round of applause. And of course, if you guys have any questions, feel free to reach out to me or anyone offline. We'll certainly get you answers to those questions.